What you're about to hear is not theory, it's lived experience. We talk about heart disease in numbers and charts, risk factors, age, family history, but sometimes it begins with a moment no one expects and a life that changes in an instant. In this final episode of Running Out of Time, a physician becomes the patient. Dr. Sandra Bruce Nichols shares what it means to survive sudden cardiac death and receive a new heart in just 2 weeks. Dr. Anthony Fletcher reminds us that the leading cause of death in this country is often preventable if we recognize the warning signs early and know our numbers before crisis hits. This is not just a conversation about survival, it's a conversation about responsibility. KMOB 1003 Radio, the intelligence source.
My daughter was standing there talking to me, and I was curling my hair. That's the last thing I remember. My daughter tells me that at that moment I became incontinent of bowel and bladder, and it was apparent to her that I had died. She called 911 and began to administer CPR. The group got in, the emergency group got in, and they worked on me for an extended period of time. Only God knows why. They went out of their way to make sure there was no life left. They found a very, very weak pulse, and they immediately lifted me to carry me out to the local hospital. On lift to me, it became apparent that I had fallen on my curling iron. And on my left hip was a 6-inch burn all the way to the bone. When my daughter arrived at the hospital and my husband finally got there, they told them if I lived for 24 hours, they were sure I would be brain dead. My daughter decided she would not leave my side. And so she sat at every bedside, and she sat in that freezing room, as she stated. Something told her to get my finger and open my phone to get me transferred to where I was supposed to go that morning. And she did just that. She took my finger, she opened my phone with it, and she got the leadership at Johns Hopkins on the phone and said, "My mother had a meeting with you this morning. We need help. She died." They immediately sent over a helicopter to get me to Johns Hopkins, and my family followed over. A couple of days later, I was awakened, and I was told at that point that there were a lot of things going on and that I was in the hospital. But I didn't care. I was screaming at the top of my lungs, screaming at my daughter, who kept saying, "Mom, please calm down." The doctors and the nurses and the aides came running from every aspect. And when they realized what I was screaming, they stopped and said to me and to my daughter, "Just give her her phone." You see, I was screaming for my phone so that I could call my office, so I can tell my job not that I had died, but that I'd had an emergency, and I never said the emergency was me.
Thank you for that, Dr. Nichols. We really appreciate that. They give people insight, to who you are and what you went through. And I want to turn it over to Dr. Fletcher and have him to give us, some more information about who he is. And you can start any way you want to, Dr. Fletcher.
Well, thank you, Mrs. Nichols. Certainly, you just heard a very powerful testimony of a patient, of an individual, of a human being, of a Black woman who told you about her episode of sudden death, her presentation to a medical facility, her appropriate assessment and diagnosis, the input of her family, the role that they played in terms of making sure that she got the appropriate care in the appropriate place. This is a very powerful story that not many people get a chance to tell. So many people have sudden death, and more people of color have sudden death and don't survive. So you've just heard a very vital testimony that I think is very instructive and very telling in terms of what we should understand and hear. Part of my journey was to be sure that individuals like Dr. Nichols, or individual who may be Mrs. Nichols, or individuals who might be Miss Nichols, or individuals who might be just a Black woman, all have the same access to care, all have the same availability of the appropriate evidence-based therapy and treatment, and in her case, transplantation. As a young man, as I looked around the environment in which I was born and raised and saw many, many people who were sick and many people who were dying young and many people who were dying old but suffering needlessly, it became a passion of mine that I wanted to be sure that I would be able to become a physician, to be sure that each and every individual was treated to the best possible level of care that's possible. But more importantly, they were treated with dignity and respect, and that they certainly had the opportunities to have the best possible medical care made available. As I ascended through the ranks and became a cardiologist, it became a passion of mine to figure out why so many people who look like me, talk like me, why they seem to have diseases at such an earlier stage, why they seem to present in a much sicker condition, why sometimes they were not afforded the same medical care. I know when I first met Dr. Nichols, she was practicing medicine in a rural community in Arkansas and used to send us patients. And I used to tell my partner, where in the world is she finding all these sick patients? I mean, these patients should have been here 10 years ago. But that was the nature of the beast of the community in which she was serving. And many times she met these individuals for the first time prior to that transfer. So the task began early in my career. How can we make a difference? How can we get these individuals sooner? How can we help prevent these conditions? And that started my trek through the field of medicine. And that formed the foundation for why we serve at so many different capacities, whether it be local, state, federal, national, and international, to make a difference so that every individual, regardless as to color, creed, race, sex, religion, has access to the same quality of care, the same evidence-based treatments, and the same opportunity to die 3 times and have an opportunity to be with us today to share this very powerful story.
Thank you both for that. You know, in filming these and spending the time with the two of you, people see who you are now, but they don't see what you went through to get to where you are. So I appreciate that we get a chance to know you personally. Dr. Sandra Bruce Nichols, I mean, a physician, a doctor, that she had a heart transplant, that she actually died. I mean, you think about laying on a floor, but a curling iron is sizzling your body. And I think she's 6 inches.
Yes.
And you don't feel that. She went through that, and as Black people, as brown people, as women, one thing she said that stuck with me through all of that, dying, being in the hospital, the only thing she could think of was calling her job to let them know that it was an emergency. Think about that again. Calling her job to let her know she had died, and that was her thought. What are we doing? What are we doing? I'm going to go, because that's so deep, and we're going to have to come back to that. I think I'm going to have to do a one-on-one episode with just Dr. Nichols on with women. And what is it that we feel like we have to be, or what is it that our jobs have done to us to make us think that we have to be on and performing 24/7, even in death?
Mhm.
So let's go into this. So in one sentence, what's the most urgent truth that our listeners, our viewers all over the world, we've had over 87,000 people to tune in to listen to this. We've had teachers from schools from all over the world that they want to show this, in their classroom because, see, they thought that heart conditions was an old person thing. But Dr. Fletcher came back and said, hey, we've had people, that were probably military members and they died during a war situation. They came in and they were in their 20s. And I think he said they already saw the symptoms, the buildup. So, what is the most urgent truth the public must understand about heart health right now? Dr.
If
Fletcher?
I may, if I may go, so heart disease is preventable, and heart disease is something that if we start early in our lives, we can modify all of the risk factors with the exception of the inheritance, who our mother and fathers were.
That's good. Dr. Nichols?
You recognize that your life is not collateral damage. Your health is not optional. Your rest is not selfish. And we see this, Pam, as you mentioned earlier, in so many women. All women seem to feel like they have to not only bring on the bacon, cook it up in a pan, and the rest of that.
Yes.
And so why is it that we cannot recognize that we must be steward of our own purpose? We must recognize that awareness is the first act of self-care.
Fletcher, from a cardiologist standpoint, what is the biggest missed opportunity for early intervention in patients?
Well, I thank you for that question because I was going to dovetail on the end of Dr. Nichols' statement. Prevention is the key. Obviously, we want people to know their symptoms, recognize their risk factors, but prevention is the key. One of the things I tell my friends all the time when they say, if I get sick, I want you to take care of me. And my comeback is, come to me the heartbeat before you need me, because then we have the most options. So I think what we have to understand is that even in childhood, there are things that we need to do early in life that will keep us from having the risk factors, the hypertension, the obesity, the diabetes, the high cholesterol. It's about how we eat. It's about our activity levels in terms of exercising and keeping lean body mass. It's about our social habits, avoiding excessive amounts of alcohol, avoiding tobacco in all forms, and avoiding some of the social drugs that are out there. Those are key things in the early parts of our lives. If we do those things in our early teens and our early 20s, the chances of preventing the development of cardiovascular disease in any form is extremely, extremely high, other than if you had some sort of congenital disorder that you were born with. So prevention is key. And I think that's what we need to learn: how to eat, how to exercise, how to optimize our care, do preventive checkups, which is one of the areas where we get into problems of access, which I'm sure we'll talk about later. But that is the key point. Prevention is the best form of medicine that we have, the best therapy that we have. And if we can achieve that, we can see significant changes in the morbidity and mortality in our people from cardiovascular disease.
One of the questions that is not on here that my staff said others wanted to hear, and this is a two-part thing. When someone come in and they're in cardiac arrest, and you're called in, what happens? What's the surgery like? What happens through all of that? How long is it? And they want to know from Dr. Nichols is, once you wake up in the morning, what was that care like day after day after day? How long did it take for you to start feeling somewhat normal? What was the pain level like? They want to hear this. So, Dr. Fletcher, from the time the emergency room or however it happens, when they come to you and they're in full cardiac arrest, what happens?
So when an individual presents to the hospital with cardiac arrest, and I think Dr. Nichols gave a very vital piece of information in her description, her cardiac arrest treatment started before she got to the hospital. The key was her daughter recognizing that she was not breathing, did not have a spontaneous pulse, and immediately started CPR, and obviously call 911. That is key. If you don't start CPR, the longer the heart is without circulation, the longer the brain is not getting adequate blood flow, the less likely it is that you're going to have a good outcome. So the key is CPR, and it's another reason why people need to learn CPR. Every household should have someone who knows how to do CPR. Once you get to the emergency room, that is one of the few major medical emergencies where time is of the essence. The sooner you get to that patient, the sooner that they can be defibrillated or shocked, even if it's in the field by local AEDs in stadiums or schools, etc., or when the EMTs get there, if they identify that rhythm, the earlier you can get shocked, the better. And so if you've gotten to the emergency room and you've not been shocked, that is the next phase. So CPR will continue. They will establish breathing in terms of intubating you, putting a tube in your airway so that we can adequately oxygenate you. And then we go from there. Depending on the nature of the rest, there are various algorithms with medications and protocols. If the person is in the midst of having an acute myocardial infarction that we refer to in the lay world as a heart attack, then there are immediate steps to get that patient to the cardiac catheterization laboratory as early as possible. The door to balloon times, we like that 90 minutes or less. And that's so that we can identify the culprit artery, if that is the cause of the arrest, and get that artery or arteries open as soon as possible to restore blood flow. And after that is done, then obviously there are different supportive mechanisms, whether it's medications, obviously the patient is on the ventilator, and sometimes there are accessory supports for circulation, such as intra-aortic balloon pumps, Impella, ECMO. Those are just sort of various forms for advanced support when needed. And so this is all time dependent. And it's also very important in terms of where you live. Zip codes make a difference. If you live in rural America where there are not cardiac catheterizations and cardiologists, then obviously your chances of survival are somewhat diminished. Hopefully, in many cases, they have networks set up where you can be stabilized and transferred urgently to an advanced cardiac center. So it's important, again, that you get to the hospital as soon as possible and that the appropriate treatments and care are started.
Wow. And so all of that happened. And Dr. Nichols, you wake up and what are you feeling? What are you seeing? What are you thinking? What's going on?
When I awakened and was screaming for my phone, first and foremost, I had a 3rd-degree burn on my left hip. A 3rd-degree burn typically goes to the 3 layers of the skin, and I stayed it all the way to the muscle, through the muscle. I had no pain because all of those nerve endings had been burned. I do recall being on multiple drips of medication, and they kept trying to keep me calm and kept saying, if you cannot calm down, we're going to have to put you back on the vent. Okay. The interesting thing from a psychological and mental perspective, I was smart enough during that time to want my job, but I could not count from 100 backwards. The individuals who were doing the assessments told my family, please don't make any noise, don't say anything, don't make any facial feature as we begin to test for mental status. And of course, as always, I thought I was nailing it, and I could not count from 100 backwards. And so there were multiple things occurring when they would come and dress the wound. After a while, I would have to take a small amount of Percocet or something to help with the pain because they would have to dress it on twice a day. In fact, I believe some of this was probably more emotional than anything because they told me once I awakened that I would have to have a heart transplant at some point. Like many people in that situation, typically take up to 8 years to get a heart transplant. And, none of that bothered me because I was still thinking that I had it all together. I had work to do, that I would take whatever device and go back to work.
What a story. What a testimony. Dr. Fletcher, everything Dr. Nichols just said, that next day, what is that like? And she said that she received that transplant within 2 weeks. That's a lot. And then she said the surgery was so long. How long does a surgery like that last? What does it entail from a cardiologist's point of view?
Well, let's step back a little bit. I want the public to realize that everyone who has a cardiac arrest doesn't have to have a transplant. Many people survive their cardiac arrest, things are corrected, and, they go home and lead a good, long, active life. So there is a small percentage of people, if the heart is severely damaged and not capable of maintaining the adequate supply of blood to meet the body's demands, and that heart failure that we call it is refractory, then they go through a series of things to support that heart. Dr. Nichols, as she so eloquently described, was certainly an exception to the rule from the standpoint of the pace or the speed with which she got that transplant. Again, as she certainly admitted, because of her stature and her connections, she certainly had access to a more rapid evaluation and transplantation. But, for those individuals who are refractory and who do need transplantation, whether it's urgent or delayed, that surgery usually takes multiple hours to do. Essentially, what you're doing is you're receiving a heart from a donor that otherwise was healthy, who unfortunately, that heart becomes available because they had some sort of catastrophic event occur in their lives that did not affect their heart. Many times there are accidents, for example, motorcycle accident, car accident, etc. But that heart is taken and becomes the donor heart that goes to the recipient, such as Dr. Nichols. Mm-hmm. There's a lot of things that go into play here. There has to be a certain amount of similarities in a lot of the body characteristics, blood types, etc., for that transplant to be a viable candidate for the individual who receives the heart. Unfortunately, in this country, there are many more people who need transplants than there are transplant available hearts. And so that's another thing that comes into play. Some of those individuals end up getting what's called a left ventricular assist device called LVAD, and that is a mechanical heart. And so many people get mechanical hearts and they're sent home with those mechanical hearts. Sometimes you get those mechanical hearts as a bridge to transplantation. And so certainly there are many scenarios by which this can work out. But in Dr. Nichols' case, obviously she got the transplant successfully. She did well. The surgery is certainly a team of surgeons that performed this operation for multiple hours. After the transplantation, she's going to be in the ICU, sedated for quite some time on a ventilator, on various strips and medications as her body adapts and gets accommodating to the new heart that she just received. And then obviously after that, she's off the ventilator. There's going to be a series of physical therapy sessions to kind of get her stronger, get her up, move around, etc. The blood clot is certainly one of the things that can happen when you're a patient that's sick and in the bed, not mobile, and also the trauma from the burn. That certainly puts one at risk for blood clots. Other individuals can get blood clots who obviously haven't had transplants, but certainly that is a potential complication and a potential setback. And so certainly that was appropriately managed and treated and certainly allowed her to move forward with her transplantation. So I think it's just a beautiful scenario of events. I think one of the things that we strive for as physicians, and I personally strive for, is to be sure that each and every individual that is in need of a transplant can be appropriately assessed and evaluated, and without bias, considered as a potential candidate and given the potential opportunity should the heart become available that matches their physiology and body. And so I think that's one of the keys that we have to think about is, number one, people need to realize that we need to think about being transplant donors, yes, whether it's heart, kidneys, lungs, retinas, etc. So that's one of the things that we need to kind of stress with the community. And then number two, we need to educate families and patients about the right questions to ask about, perhaps seeking the opinions for whether or not they are a transplant candidate. Unfortunately, there are certain conditions and medical conditions that make individuals not a good transplant candidate. So everybody who needs a transplant doesn't always qualify. Certainly in Dr. Nichols' case, that was not the problem. But there are many aspects to transplantation that need to be taken into consideration.
Thank you for that. One of the things that you hear a lot more than the heart transplant is pacemakers. When do, the people that need pacemakers, what happens with that? Is it that the heart slows down a little bit? Is it skipping beats? Tell me about pacemakers, and when do you recommend that a patient of yours, get a pacemaker?
So pacemakers are very common. You don't have to have a cardiac arrest to need a pacemaker. There are some conditions from birth, congenital conditions, where young people need pacemakers. And so certainly it is not uncommon. Many times as life goes on, just the wear and tear of ailments to the heart, whether it be heart attacks, whether it be scarring that occurs from infections or longstanding hypertension, the electrical system of the heart can become dysfunctional.
Mhm.
And so in those scenarios, individuals need pacemakers. So pacemakers are very, very common. If you have heart rates that are too slow, if you have heart rates or rhythms that are out of sort of rhythm, that, the appropriate cadence of conduction of electricity through your heart is somewhat dysfunctional, they need pacemakers. There can be inflammatory conditions such as systemic lupus, for example, that can lead to the need for pacemakers. There are many conditions that can lead to one needing a pacemaker. So certainly pacemakers are very, very common, much more common than transplants. They are readily available. We can go to the shelf and get a pacemaker for each and every individual that needs one. And I think the important thing to pass on in the conversation is you can lead a long, normal life with a pacemaker and do all the things that you generally enjoy doing with just a few exceptions.
I have a question. Thank you for that, Dr. Fletcher. A question for Dr. Nichols. You mentioned about your daughter and her being able to, start with CPR. So what conversations should families be having about heart health and CPR, with their family? Because not everybody's family, I'm sure, knows CPR and what to do. And so if you can give us, what conversations should they be having with their family, their children, people that live with them?
That's a great question, Pam. And I would include in that question not only about what they need to do to prevent these things occurring, but talking with your families about transplant. Once again, I want to always give a shout out and how deeply grateful I am to the family of that person that was 22 years old. And so now I have in my chest a 28-year-old heart because I've been living with it for the last 6 years that thought it was necessary to make that donation. And I think we as a race of people should be having that conversation as well. We start doing your blood pressure when you're in elementary school. We know that our country, our nation has a challenge with obesity. It's in all ages, it runs in families. And I believe that one way of preventing this would be to have some way of encouraging everyone to do those things as a family at a younger age to keep each other accountable. We know that hypertension is the silent killer because you really don't know it's occurring. And I think it's time that we be silent no more about that disease and to begin to look at opportunities to make a difference. And by the way, everyone's phone now has the capability of checking your blood pressure.
Thank you. Thank you, Dr. Nichols. Dr. Fletcher, if prevention works best early, what screenings and evaluations are happening too late?
To again dovetail onto a point that Dr. Nichols just made, one of the things is that many states have now regulated and made it mandate that CPR is mandatory prior to graduating from high school.
Wow.
And I think that needs to be pervasive throughout the country. And certainly, just like everyone probably should learn how to swim, everybody should learn how to do CPR. The Association of Black Cardiologists has just started a very nice initiative. We call it the ABCs to Heart Health. and it's ABCs to heart health action. A being ask for your key numbers, blood pressure, cholesterol, glucose, BMI. B, be aware of what they mean and what in range looks like for you. C, create a plan, commit to action, and check in to stay on track. So again, this is something that we inaugurated for Heart Month this year as a national campaign. So ABCs to heart health. Blood pressure is key. And I think it's also important that we know family history. You know, if mother and grandfather and uncles, aunts, cousin, aunts have a history of certain diseases, specifically now in the cardiovascular realm, it's possible that that will happen to you also when you get older. So we should talk about, you know, what happened to Uncle John, for example. He had a heart attack when he was 40. That's an early age to have a heart attack. So again, we should be screened when you get your routine pediatric physicals. Cholesterol should be checked, blood pressure should be checked, sugar should be checked. Your kidney function is certainly documented, and follow those things. You know, as we go in for sports physicals and things, those things certainly should be repeated and evaluated. So routine maintenance of general preventive care, screenings, they're very important. One point that Dr. Nichols made, and I want to expand on that, heart disease is the number one reason that people die in this country, not cancer. And so many people think that cancer is the number one thing that they die from. Cancer is very prevalent, very important, should not be ignored, certainly should be screened. But the number one thing we need to think about is cardiovascular disease. And so certainly that's just part of the discussion that we need to have as we're young, that needs to be taught in school, that needs to be discussed with social organizations and clubs, fraternities and sororities. That is the number one reason that we need to follow our health and to be certain that we're keeping these numbers in our minds and when appropriate in check.
What Dr. Fletcher and Dr. Nichols have shown us is that true survival begins upstream. It begins before the emergency, before the diagnosis, before the story becomes a headline at a funeral. We are losing some of our brightest lights 10, 15, even 20 years too early. That is not just a medical crisis, it is a community tragedy. And it is a tragedy we have the power to interrupt. So take what you've heard here, share it, use it. Let it be the reason someone schedules the appointment, learns their numbers, speaks up sooner. Let it be the reason someone sees next year and the year after that, because knowledge is only power when it saves a life. Thank you for being part of this journey. KMOB 1003 Radio, the intelligence source.